Why the complications of diabetes mellitus occur? How do they occur? Why do they occur? So the pathogenesis of complications also you should know. So if you remember, there were acute metabolic complications like ketoacidosis, hypoosmolar, non-ketotic coma, hypoglycemia. Then you have late complications like atherosclerosis, microangiopathy, nephropathy, diabetic neuropathy, retinopathy, infections. Secondary complications we saw, secondary complications were like cataract, ischemic heart disease, bowel infarct of bowel, urinary tract infections, then diabetic ulcer. Some little pathogenesis was covered in the last video like microvascular destruction, macrovascular destruction, microvascular destruction, neuropathy, nephropathy, retinopathy. Then metabolic protein glycosylation, again same thing, neuropathy, nephropathy, retinopathy. Macrovasculars, when they're affected, they can have infarcts, etc. Then in metabolic, you will have sorbitol formation. This will affect the aorta, lens of the eye. That is why there is retinopathy. Okay, lens of the eye, cataract. Cataract, sorbitol will lead to cataract, kidney, nerves, again, nephropathy, neuropathy. Protein glycosylation will lead to all these things again. What is BM? BM thickening. That's nothing but the basement membrane thickening, okay? Vascular basement membrane thickening. Hold on. So we have added the information here. Basement membrane thickening because of protein glycosylation. Then infections because of defective cell-mediated immunity and defective functioning of the polymorphonuclear cells. Fungal infections, bacterial infections, UTI, pneumonia, tuberculosis even, okay? I think we have already covered secondary complications. Have we or haven't we in this video? We have covered, right? So let us move on. Pathogenesis of these complications. How do these complications actually occur? See, what happens is, first of all, there is protein glycosylation. Okay, what is this protein glycosylation? Let's read that. So what happens? Free amino groups of proteins. Okay, proteins have free amino groups. These free amino groups, they bind in a non-enzymatic mechanism, they bind to glucose. These bind to glucose. How? In a non-enzymatic mechanism. Okay, they bind in a non-enzymatic mechanism. They bind to this glucose, and this is called as protein glycosylation. Now, what happens if this happens? Various proteins will undergo chemical alterations. Example, hemoglobin. Hemoglobin will get glycosylated. Then the lens protein. Lens crystalline protein. Where is the lens? In the eye. So these also they undergo glycosylation, and even the basement membrane of body cells. So many places. So what happens? This hemoglobin will go on to become a glycosylated hemoglobin. That is nothing but HbA1c. This A1c can be small. HbA1c can be small. Let me make this 1c small. This HbA1c, okay, or glycosylated hemoglobin, it can also be used for monitoring glycemic control in diabetic patient. Okay. So what exactly is happening here? As and when this glycosylated protein, they start depositing, they start becoming, subsequently they become stable and irreversible. And they form advanced glycosylation end products. That's called as age. Okay. They become subsequently, they become stable and irreversible, okay, and they form AGE, that is advanced glycosylation end products. Advanced glycosylation end products, fine, and they produce a lot of things like thickening of vascular basement membrane, etc. Fine. Thickening of basement membrane, etc. happens. So we have covered this Non-enzymatic protein glycosylation. Next thing we want to cover is the polyol mechanism. Polyol pathway mechanism. So till now what we saw that the protein becomes glycosylated protein. Then we will see polyol mechanism. Now polyol pathway mechanism, look at this. Glucose is there, right? Hyperglycemia. In this, what happens? This glucose will become sorbitol. Sorbitol will become fructose. So glucose with the help of aldose reductase will become sorbitol. This sorbitol with sorbitol dehydrogenase becomes fructose. This is kind of important, guys. So just pay attention here. So let me just read it out for you. Please see if you can understand. Okay. Aldose reductase reacts with glucose to form sorbitol. Okay. Then sorbitol becomes fructose. Fine. Intracellular accumulation of sorbitol and fructose results in entry of water inside the cell. Entry of water into the cell and cellular swelling and cell damage. Is this much clear? Let's do one thing. Let's take up all this in the next. There's no place here, I think. Or is there enough place for us to explain this? So what exactly is happening here? Sorbitol and fructose enter cell, or they are formed, okay, because of these enzymes in the cell. Now water enters, cell swelling, cell damage, right? Now here what happens whenever there is cell damage? Intracellular deficiency of, there will be intracellular deficiency of myoinositol. Myoinositol will become less. There will be injury to Schwann cells, that is again in the nerve, right? And injury to the retinal pericytes. So this is how there is injury to Schwann cells and retinal pericytes. Deficiency of myoinositol. Okay. Is this much clear, guys? Or is it too much for you to understand? Glucose becomes sorbitol, sorbitol becomes fructose, sorbitol and glucose accumulate, water enters, cell is swelling, cell is getting damaged. Deficiency of myoinositol, injury to Schwann cells, retinal pericytes. Fine? These are called as polyols, sorbitol, etc. This is to remind you that the cell is swollen. Fine? Let's move on to the last one, excessive oxygen-free radicals. Now, what do you mean by excessive oxygen-free radicals? In hyperglycemia, there is increased production of reactive oxygen-free radicals. Okay. So, there will be mitochondrial oxidative phosphorylation and there will be oxygen-free radicals. These will damage various target cells. Okay, that's all. Oxygen-free radicals will be there. They will damage various tissues. Okay. So, we are done with the pathogenesis of complications of diabetes mellitus. This is clear. Protein glycosylation, polyol pathway mechanism, excessive oxygen-free radicals. Okay, reactive oxygen species, look at them, ROS. Fine. So just let's go back here and look at the pathogenesis which was explained here. Sorbitol will lead to lesions or leons in the aorta, lens of eyes, kidney, nerve, basement membrane thickening due to all the deposit of this glycosylated protein, etc. This hypoglycemia will occur because of excess insulin administration, okay? It's not directly because of hyperglycemia. It is because of excessive insulin Insulin administration. Okay. And this hyperosmolar hyperglycemic non-ketotic coma is because of dehydration. Dehydration in type 2 diabetes mellitus mainly. Okay. So, loss of glucose in urine is so intense that the patient is unable to drink sufficient water to maintain urinary fluid loss. Okay. Diabetic ketoacidosis, I hope you have understood. Basically here what happens, there is insulin deficiency, right? So there is a lipolysis. Okay. So a lot of free fatty acids are formed. Liver takes up these free fatty acids and converts them to ketone bodies. Ketone bodies, example, acetoacetic acid and beta hydroxybutyric acid. Okay. Now what happens? The rate of this ketogenesis is so high. Okay. And you cannot actually remove so much of acid from the body, and there will be diabetic ketoacidosis. So this video we wanted to cover the pathogenesis of these complications. So one is the protein glycosylation, which leads to the problem. Then you have the polyol pathway mechanism. Then you have the oxygen-free radicals. Okay. This much you have understood, I hope. See you. Bye-bye.